Patients who have hereditary ATTR amyloidosis are born with a mutation where the liver produces a protein called TTR or transthyretin that misfolds and deposits in multiple organs of the body: the heart, the peripheral and autonomic nervous system, the bowel. These patients have very poor quality of life due to organ dysfunction related to the deposition of the amyloid protein. And until this year, the only effective therapy was liver transplantation, which is not widely available, which replaces the production of the abnormal protein, genetically inherited, with a normal protein that is produced by the new liver. This year, for the first time, agents have been developed that interfere with this process and offer the hope of improved quality of life and organ function for these patients. The mechanism in which TTR amyloid is produced is the liver, with its genetic mutation, produces a TTR messenger RNA. The messenger RNA translates to TTR protein that deposits in the organ. Inotersen is an antisense messenger RNA that binds to messenger RNA, causes it to break apart, and prevents its translation. As a consequence, the levels of the TTR protein fall 75 to 80%, and as a consequence of that, there's no precursor protein to lay down as amyloid anymore, and these patients therefore stabilize and can improve in terms of function due to the fact that the inotersen prevents the production of the culprit protein. So the treatment with inotersen is highly effective, but monitoring is required. In the early stages of the disease, the agent was responsible for causing serious reduction in the platelet count, and in rare patients, kidney dysfunction manifest by glomerulonephritis. So these patients require periodic platelet counts, measurement of the urine, protein, and the creatinine. In the open label extension trial, once these measures were instituted, there were really no problems whatsoever. Patients get occasional injection site reactions to it. Otherwise, this is a remarkably well-tolerated agent. In the original trial, patients were randomized to inotersen and placebo. Patients who were on placebo had a progressive deterioration, both loss of neurologic function and a decline in the quality of their life. Once the open label extension occurred, placebo patients got active drug, and as soon as the drug was initiated, that decline in neurologic function and decline in quality of life leveled off, and these patients stopped deteriorating the way we would have predicted based on 56 weeks of therapy with placebo. We think that this disease is under-recognized, and now we're undertaking a major educational effort with hematologists that are referred these patients all the time for a different diagnosis, and educating neurologists and cardiologists that this disease is out there and treatment is now available for them. So there's an unmet educational need. There's also a major educational issue with patients. This is an inherited process. So half of their brothers and sisters, half of their children, half of their aunts and uncles are likely to be carriers of this and may develop symptoms that they don't associate with the underlying cause of the disease. It's also appropriate to develop successor compounds that will depress TTR even further, require less frequent administration, and are not associated with the current side effects of glomerulonephritis and low platelet count.